Good morning, guys. My name's Kyle. I'm a student physical therapist assistant through the University of Findlay, and today we're going to be talking about improving the biomechanics of an athlete's squat. So the learning objectives for this in-service are going to be, during the in-service, the learner will describe to the teacher the importance of proper squatting kinematics in an athlete to improve the athlete's performance, function, and maintain safety. Following the in-service, the learner will be able to accurately demonstrate motor control training using either tactile cueing or visual feedback to improve the patient's squat performance. The next learning objective, after completion of the in-service, the learner will be able to demonstrate to the patient the importance of lower extremity multi-joint mobility, muscle length, and proper muscle activation for improved biomechanical advantage. The next one is, after the presentation, the learner will discuss with the teacher the importance of having the athlete squat both prior to and following the learned interventions. This will allow the athlete the opportunity to better understand the appropriate squatting mechanics to facilitate improved patient outcomes. And the final learning objective, following the presentation, the learner will be able to instruct an athlete in squatting and evaluate for any possible impairments. That will then be expanded upon through the following criteria. So, factors that contribute to the improved squatting mechanics, we're going to learn how gluteal inhibition or glute weakness can impact these, as well as poor joint mobility, inefficient muscle length, poor motor control, and finally, a low arch and imbalances of the foot and ankle, and how that can play a role in affecting the athlete's squat. So let's do our first breakout session. I want you guys to take this opportunity to break out into small groups and discuss the following questions. 1. How do you think gluteal inhibition can impact an athlete's squatting pattern? I'd also like you to discuss with your partner how would improper biomechanics impact the athlete's squat, meaning anteversion of the hip, perhaps genu valgum when squatting, as well as pes planus. And then who do you think is at greatest risk for having these biomechanical deficits, males or females? How does single leg squatting differ in regards to a double leg squat? And can this tool be useful in the clinic? Have you used it in the clinic previously, or seen someone else use it in the clinic? And finally, if you have time, please discuss what are some musculoskeletal impairments that could attribute to poor squatting mechanics. Okay, so now that we've followed up with our breakout session, let's move on to the next part of the lecture here. So we're going to get into the lecture material part 1. So Hogg et al. Hypothesized that poor perceptual motor function in females would correspond with exacerbated squatting mechanics compared with males of similar perceptual motor functions. Function was partially supported. So they discovered that sex did moderate the relationship between perceptual motor performance and single leg squatting mechanics. Essentially, whether male or female, they did note that the sex did have an association between both perceptual motor function and two-dimensional frontal plane squatting kinematics. During the study, females were found to have who were found to have slower reaction time were seen to actually experience compensatory movement patterns that resulted in more medial projected knee angles, or other words, dynamic valgus, right? Lack of motor control can lead to compensations at the hip, causing adduction or internal rotation, antiversion, all that stuff, resulting in bowstringing of the patella and excessive stretching of the medial retinaculum. So definitely setting that athlete up for an increased chance for injury and pain, especially in the long run, or perhaps under higher loads. Critical thinking question. Does the fact that females have an increased frontal plane squatting mechanics in regards to their compensation, does this lead them to also be at higher risk for ACL injuries? Feel free to answer that question in your head. And then perhaps if you have time, you can discuss that with your partners throughout the lecture. Okay, lecture material part 2. So the impacts of gluteal insufficiency. So with gluteal insufficiency or glute weakness, we see increased demands from other muscles and joints, right? We also see an increase in genu valgum because the body is trying to create essentially a false sense of stability. And we also see increased hip anteversion of the femur. Again, just trying to achieve a false sense of stability here. As a result of these compensations due to gluteal insufficiency, poor biomechanics when squatting can increase soft tissue stress of the tibiofemoral joint and the patellofemoral joint as a result of internal rotation and adduction of the femur in relationship to the tibia. Local resources. So I think it's important for us to have the conversation with our patients, depending on what they have going on. Maybe it's tightness, right? Maybe it's tightness throughout the hip capsule or the other muscles. So perhaps try yoga, right? This can improve general increased mobility and flexibility of the athlete. Also, it's a nice balance, especially to all of the compound training that sometimes they're doing and the compression forces. So yoga can be a great way to address, strength, mobility, flexibility, but also giving that patient almost like a active rest day. So something definitely to consider with your athletes. Also, I would recommend, visit a local running shop. Okay, make sure we're educating our patients on the purchase, the necessity for purchasing a proper shoes or orthotics. I think we could all probably think of a situation where a patient came into the clinic, maybe they forgot they had PT, maybe they were running errands, and they're wearing Crocs or they're wearing, Hey Dudes or loafers, something like that. Yeah, obviously we wouldn't want to perform, heavy squatting. Ideally, we wouldn't want to perform even, any squatting at all if we don't have that proper arch support. So making sure that we're addressing that. So a couple key factors here: having a flat foot can lead to a navicular drop and calcaneal valgus, right? Whether compensated or uncompensated, we can see these two things occurring in the athlete. This sets the athlete up for faulty biomechanics prior to even squatting or performing the movement pattern, right? Due to having a flat foot, compensations can be seen up the chain. Again, genu valgum, anteversion of the hip are going to be commonly seen. So don't mean to sound like a broken record, but making sure that if we do see those patterns, rather than looking specifically at that aspect, maybe we can look down the chain, right? Maybe we can look at the foot and ankle and see what's going on there. And then finally, and probably most importantly, seeing a PT who specializes in sport performance and the athlete. Okay, so lab activity 1, here we go. We're going to get up, we're going to get moving. So this following slide, we're going to address the key factors, right, and the key stretches for performing a proper routine for warm-up and prior to squatting. So let's do an active warm-up, and dynamic stretching is key. I would recommend walking, cycling, marching in place if none of those other pieces of equipment are available, and just getting that blood flow, right? Following some sort of active warm-up, running, jogging, what have you, you're going to want to do some air squats, get those hips moving, get those joints moving, and get them familiar with the movement pattern that we're going to be going through. This is key, right? Because with motor control and motor learning, it doesn't take 1 repetition, 10, or even 100 repetitions. We know that it takes thousands, sometimes tens of thousands of repetitions. So repetition is key here. no pun intended, but let's get him going. Let's get him getting some air squats. Maybe we can do some lateral lunges, stretching out those hip adductors. Sometimes those hip adductors can bring that femur into adduction, resulting in poor biomechanics as well. So let's definitely address that active warm-up and some sort of an active stretching. Okay. This second lab activity, now that we're all loosened up, we got the blood flow going, right? Now we could start stretching. So this before and after picture, I was almost contemplating not putting it in the slide, but I think it's really important to see the effects that the talocrural joint, right? And stretching out that ankle and getting it preps for the demands that are about to be placed upon the body can have a huge influence on the overall squatting pattern and mechanics. So this before and after picture, no joke, this was literally done. 2 interventions got this improved this squatting pattern, and you can see based on the orange lines, you can see how there's an increase in knee range of motion. You can even see an increase in hip range of motion, right? Although there's no lines there to indicate that, I think we could all, definitely see the increase in hip range of motion. And that all comes from those black lines there indicating the increased range of motion for the talocrural joint in that ankle. So the foot and ankle joints are sometimes segments of the body that we forget to screen. Especially in athletes, right? Sometimes young athletes, unless they're coming in with, an avulsion fracture or a lateral ankle sprain, sometimes we might not even assess it. So the picture on the left shows a significant decrease in range of motion and squat depth, versus the picture on the right. You could obviously see that those limitations and those impairments were addressed. And this was with 2 interventions that I performed on myself. You can even see better alignment. Believe it or not, you can even see better cervical alignment, right? In that picture on the left, I mean, I'm extended, right? I got all that force going through the cervical spine, maybe leading some neck pain. Then you can see a better setup, better position on the right. And that's because I can get lower. I can get into a better position and have a more biomechanical advantage. So the first intervention I did was essentially just a self talocrural joint mobilization, grade 3s, grade 4s. And that was with a band. I hooked a band up to the rogue. You can even see it in the picture on the right. Because this was after I did it, you could see the purple band there on the rig. And I essentially just, faced away from the rig and put the band low on the inferior aspect of the talocrural joint on that talus. And I just kind of leaned into it, lunged forward, and creating an AP joint mobilization to increase that dorsiflexion. And then following that, the second intervention was a calf stretch, and I just performed that on the squat rack as well. So definitely don't forget to address that talocrural joint. It's so important when looking at the overall squatting mechanics of the patient. Okay, lab activity 3. So we're going to play this video, but for the lack of the due to the recording, we aren't going to play it via recording. We'll play this live. But the lab activity 3, this is going to go over reactive neuromuscular training, commonly referred to as RNT. The indications for RNT: gluteal weakness, poor biomechanics, knee genu valgum, pronation of the foot and ankle. Believe it or not. So listening to this video here on the right, you're going to see that I'm working with a patient in the clinic. And I think it's important to note the patient that I'm working with, he's probably one of the stronger gentlemen at our gym. And there's hundreds of people that attend the gym, but he's probably one of the stronger ones. But you can see when I push on his knees while watching the video, you're going to see how much he lacks that stability, right? And even though he's the strongest person in the gym, or one of the strongest persons in the gym, he has that false sense of stability. So definitely look at the before and after here after addressing that with the patient. And then finally, here are my references. Thank you very much.